I am Dharmapal Vansadia. I'm an orthopedic surgeon at Innovate Orthopedics in Houston, Texas. And my charge today in the next few minutes is to describe and discuss some of the considerations regarding blood management and DVT prophylaxis. And I'm hoping to do that today along with our experience of doing approximately 1,000 joint replacements in the last 2 years. A key to blood management at ASC is understanding that ASCs are not just mini hospitals. A patient who is hemodynamically unstable and needs to be stabilized, the options are significantly limited at ASC compared to a hospital. Most hospitals generally do not store blood products, or they have very limited, if any, access to blood banks in a hurry. And if you end up using blood products, it's not likely to be reimbursed at a ASC setting. Moreover, if a person just needs to be monitored because they're hemodynamically unstable, then they may require extended stay, and most ASCs do not have any overnight beds or limited overnight beds, and obviously there is no ICU. In addition, there's always an option to transfer the patient to a hospital. Most surgery centers will have a transfer agreement, but this is something that governing and state bodies monitor, and if there's significant amounts of transfer, then that would likely lead to a site. Given the limitations of the ASC, patient selection is key to having a successful arthroplasty outcome at an ASC. We screen all our patients with a CBC. Currently, we do not have any hemoglobin hard stops, but that is likely to change in the future with more available data. We also try to avoid high-risk patients, such as patients with chronic anticoagulation use, patients with history of bleeding disorders. We also screen all our patients for supplements. A lot of supplements increase bleeding time, and so ginseng, turmeric, omega-3s should be screened for, as they're commonly used by patients. And as a general rule, we stop all supplements 7 days prior to the OR period. There are patients who are good candidates for ASC, but for whatever reason they have a low hemoglobin. It would be appropriate to supplement them prior to surgery with erythropoietin or iron as indicated. Our current protocol is to use tranexamic acid on all patients, 1 gram just prior to the incision, and in some cases topical as needed. Obviously, during surgery, one use careful dissection and technique to avoid any excessive trauma to the tissue and bleeding. Currently, we use Cell Saver for all our hips. We've actually trained all our OR staff to use Cell Saver, so we do not use any perfusionist. In addition, we have Aquamentus that's available. If needed, we rarely have to use it, but it is a good tool just in case there's excessive bleeding. Obviously, thrombin and fibrin products are also available. These products tend to be fairly expensive and tend to have a shelf life, but it's a good idea to have them available, especially if you're doing back procedures. I personally use 1 gram of tranexamic acid in the joint for both hips and knees after irrigation. Some of our surgeons do not. I've had no issues doing this, and I recommend it. And we additionally use another gram IV right before closures. If there's excessive bleeding surgery, sometimes we'll also send patient home with iron as indicated. Next, we'll spend a few minutes regarding DVT prophylaxis and ASC considerations. DVT problem is something that's all orthopedic surgeons are familiar with. Traditionally, we've worked very hard to reduce DVTs and thereby reduced risk of PE. Despite all sorts of chemical, mechanical DVT prevention techniques, the fatal rate of fatal PE has been relatively stable, being less than 0.1%. And has not studies have not shown for that to change dramatically. In fact, there has been the other problems associated with trying to do too much to prevent DVT, such as increased bleeding. Literature has shown increased mortality, increased risk of infection. So it's really key for us to find balance for this particular. Who is at risk? Patient selection in an ASC setting is paramount, and so people who have history of DVT, that's the number one predictor of having a future DVT. So screening all patients for DVT is extremely important. Obviously, other considerations include people who have had cancer, obesity, history of other chronic problems are at increased risk, although this risk have not shown to bear in other long-term studies. What is the current recommendation of the Academy? Few important considerations. They do not recommend against routine DVT screening prior to surgery for people who have no history of DVT. They do not recommend screening for other major problems except for asking for patients about prior DVT and PE history. Other considerations, they do recommend that if patients are at risk for PE only because of surgery, then it is appropriate to use pharmacological or a mechanical or both. If patients are actually at a high risk for DVT, i.e. they have a history of DVT, there's a medical condition, and obviously they're going to have surgery, then it is appropriate to use both pharmacological and mechanical prevention methods. Another recommendation from the Academy is to mobilize patient early. Maybe advantage of ASC is that because it's a same-day discharge, patients mobilize early by default, and data may prove in the future that these patients done at ASC are at lower risk for DVT. We don't know yet, but more data to follow on this. Our current protocol is to use aspirin 81 milligrams twice a day for a majority of our patients for 4 weeks. We start this in AM post-op day 1. In addition, I personally use TED hoses and mechanical compression on all my patients. Some of the other surgeons at the surgery center do not like this due to patient complaints, but I generally have not had many major issues with it. Some patients are more amenable to compression socks. Patients that are high risk with a history of DVT or PE, we use Xarelto versus Lovenox, and this is mostly based on which drug we choose is based on their insurance coverage and cost. And so in summary, if you're going to do arthroplasties at ASC, you need to have a good protocol for blood loss management, good patient selection, universal compliance with all surgeons using these protocols so there's no variance and patients don't fall through and have a complication, and having a good transfer agreement with the hospital and a plan to transfer patients who are unstable. In mobilized patients to avoid DVTs, and in our experience, 81 milligrams of aspirin twice a day has been adequate.